Welcome back to NewsX World. I'm Kriti Mehta and you're watching FutureX, the show where we examine the ideas, innovations and ethical questions shaping the future of the world. Today we turn our focus to the rapidly evolving frontiers of medicine, biotechnology and artificial intelligence, and more importantly to the ethical challenges that come from them. From CRISPR gene editing and organ transplantation to AI in healthcare, pandemic policy and end-of-life decision making, the questions we face today will define how humanity navigates health, dignity and justice in the decades ahead. To help us make sense of these complex issues, we're joined by one of the world's most influential voices in medical ethics. Please welcome Dr. Arthur Caplan. Dr. Caplan is a DRS William F. and Virginia Connolly Mitty Professor and founding head of the Division of Medical Ethics at NYU Grossman School of Medicine. He has authored or edited 35 books and over 880 peer-reviewed papers and has advised governments in the United Nations and international scientific bodies on issues ranging from human cloning and organ trafficking to gene therapy, pandemic response and transplant ethics. Dr. Caplan, thank you very much for joining us here on FutureX. So let's start with the first question. As a leading bioethicist, how do you see the ethical implications of CRISPR gene editing technology evolving in the next generation and the next decade, particularly in treating genetic diseases versus enhancing human traits?
Over the next decade, one of the major challenges ethically and even for religion is to think about CRISPR. And CRISPR is a technique, it's been around a little while, where you can almost use a scissors, a kind of genetic scissor, take out a bad gene, put in a good gene. It's been done a number of times. There are certainly people who've had their diseases fixed when genetic disease by using this CRISPR technique. But the CRISPR technique can be used not only to repair bad genes that cause diseases, but perhaps to replace regular normal genes with genes or genetic messages that would improve, enhance human performance. And I think we will see efforts to do that. I think there are many, many people who would be willing to try that around the world. There are many people who would try it on their children to try and give them an advantage. I don't think CRISPR is safe enough yet and won't be for many years to use it for enhancement or improvement or optimization. We aren't precise enough yet using the technique. So I would favor restricting it, international agreements, international law, professional society saying you can't do this yet until we get more use in humans for fixing diseases and even in animals for fixing diseases. But yes, I do think maybe 10 years from now, we will start to see efforts to improve intelligence, strength, the body's immune reaction to disease, many other traits using genetic engineering, CRISPR, to do it.
Dr. Caplan, you've also written extensively on organ transplantation. What reforms do you advocate for people to address the global shortage of donor organs, and how might innovations like xenotransplantation change the landscape?
One of the most interesting current procedures that we see in medicine around the world is organ transplantation. And people know that there are those who have kidney disease who get new kidneys, people who need a new heart due to heart disease. And it's also the case that we're starting to do transplants for things like facial injury, a new face, a hand transplant for someone who's lost a limb, and even transplantation of organs like the uterus, someone born without one, that happens if they want to have a baby. So transplant is in a stage of great advancement in terms of different types of transplants being done. But we also are short on organs. Around the world, most organs come from those who die who donate them. But there are still many people who have reservations about donating their organs. The most important thing we can do is to try and encourage that when people die, that they are willing to say, yes, you may use my organs, or your relatives giving permission to do it. That is the fastest way to save more lives, help people who need new limbs or who might want to get a uterus. Beyond that, we're working at NYU on trying to use animals. And the animal we've uh, sort of focused on is the pig. It's partly due to the pig's size. It's about the right size to support an adult human. Weight wise and size of organs are about the same. And we know more about the pig in terms of how to genetically change them when they're born to make their organs more acceptable in human bodies. That still is, however, a couple of years away. I think it's a help. I think we will see pig transplants offered in many places around the world. It raises ethical issues about, is it acceptable to kill the pigs? And I think the answer is yes, to save human lives. I think sacrificing a pig is acceptable. And if we really cared about pigs, what we should do is eat fewer of them because they're raised a lot for meals and human consumption. And we could certainly cut back on that. And that would benefit pigs a lot more. And there are ethical issues too about, is it acceptable to use a pig organ? But in my discussions with religious leaders, if you're going to save a life, almost all will say then you could accept a pig organ, a pig heart, a pig kidney to save your life or the life of your family member. Other ideas are we should learn and are working on how to freeze organs. Right now, it's an emergency when you do a transplant because someone dies and you have to get an organ, and everybody has to rush to the hospital to put it in because the organs don't last that long. But if we knew how to freeze them, we could create organ banks and pull them off the shelf and not have this kind of emergency crisis when someone needs a transplant. Last idea is more people might want to be living donors. Some people volunteer to do that and give up a kidney. Some people get paid to do it. I don't favor that solution because the payment systems constantly wind up exploiting people. We've had issues in many countries around the world where poor people said they would be paid to give up a kidney to someone. They got bad health care, they didn't get their money. Bad people ripped them off in terms of taking the money and charging the person for travel and medical expenses and other things that were bogus. So I don't think that's easily enforced, the paid system. I don't think that's the solution. In the long run, I think we need more donors. We're going to need to use animals. We're probably going to also need to figure out how to freeze organs.
Doctor, in your opinion, how should governments really balance individual rights with public health during outbreaks, such as mandating vaccines or implementing lockdowns, drawing from your expertise in medical ethics?
One of the ethical legacies of the big terrible COVID pandemic was the need to figure out how to balance individual rights and choices against the public good. And governments around the world answered this question differently. In China, people were quarantined by state order. If they had COVID, locked in, and they couldn't protest or do anything. In the United States, after an initial round of vaccine mandates, Americans rebelled and said they wanted more freedom of choice, they wanted more autonomy, and they rejected mask mandates and vaccine mandates and mandatory quarantine. So what is the right ethical balance? Obviously, if you can do public health interventions, you want to go after the least intrusions on people's lifestyles, on people's choices, on their freedom. No one would disagree, I don't think, with that. But public health sometimes requires interventions in the public good that require mandates or coercion or force. Someone is known to have HIV or tuberculosis and they're still out infecting people. You may need to lock them up, and they may not like it, but that's how it has to be. In addition to protecting against infection, we also need to protect people, say, in the vaccine or mask areas for infectious disease, who can't be vaccinated. Newborn babies don't have immunity. They can't be vaccinated against most diseases. People who are elderly, they lose their immunity. They need others to vaccinate so they don't make them sick. People get cancer treatments or transplants, their immunity is down. So part of the argument that government needs to make is to protect weak, vulnerable, and frail people. We may need to do things that people themselves won't choose to do or don't want to do. It's a tough balance, but personally I think protection of the vulnerable and control of the spread of infectious disease does justify some government temporary intrusion into liberty, putting the public good ahead of individual choice. That's not always popular, and it builds a lot of resentment when people are told they can't go to work, can't go out with their friends, have to wear a mask, have to do something they don't want to do. But if we want to maintain health in the long run, sometimes I think we have to take these steps in the short run.
Right. Dr. Caplan, finally, what do you think are the biggest ethical challenges facing end-of-life care today, especially with advancements in life-sustaining technologies and varying cultural perspectives around euthanasia?
In my hospital, one of the biggest areas for me to become involved in patient care is end of life. When somebody is terminally ill, dying of cancer, dying because their heart disease is killing them, choices come up about what should we do to manage their dying. Can we ever accelerate their death? Is there ever a situation where, because someone is in such terrible pain, that we would say it is permissible for the doctor to give them a pill or an injection to kill them? Now again, these are people going to die, they're terminally ill, so it's not like we're going to take away life in our hospital from someone who would have lived. And the issue isn't about cost, and it's not about the burden of care. It's literally about suffering and relieving suffering when death is imminent. We've passed a law in New York State, joining 13 other states now in the US, that allows a patient to request help in dying, but only when they're terminal ill, only when they're competent, only if they wait, I think it's a week, before they get the pill, and they have to swallow the pill themselves. No one can give it to them. So it's extremely restricted, but it is now legal in the US to do that. Other countries, Canada, some of the European nations, Belgium, Holland, they've expanded this to not just terminally ill people, but anybody who's suffering. I don't agree with that yet. It's too dangerous to use a term like suffering, because that term I think is too broad. People suffer because they lose their job. They suffer because their marriage gets in trouble. They suffer because their football team didn't secure a victory and they're horribly depressed. We don't want to have arguments about how much suffering is enough. It's too vague. So I think medicine has things to offer those people who don't have physical pain. We may want to give them psychotherapy. We may want to give them mental health support, counseling, but we don't offer them death. I don't think we should. So even though Canada and some nations in Europe are doing that, I think it's dangerous. I will say this, before we get into arguments about what to do in terms of having a right to die and making choices about medical assistance in dying, we need to make sure that everybody has access to health care. If you can't get palliative care, if you can't get nursing home care, if you can't get home health care, if you don't have a right to health care, I would say you have to create a right to health care before you create a right to assistance in dying. Otherwise, people are not going to trust the healthcare system. They're not going to trust their doctors. They're going to say, well, they're getting rid of me because I cost too much, or my mother doesn't, that my sister doesn't want to take care of my mother anymore, too burdensome. And those problems can't be a part of how we think about how we die.
Dr. Caplan, it was a pleasure to have you on FutureX here at NewsX World. Thank you very much for joining us. And with that, it's a wrap on this edition of FutureX. For more stories on the science and innovations shaping tomorrow, stay with us here on NewsX World.